All right, so this is the integumentary lecture that I promised to post with voice recording. And integumentary is often associated with infectious diseases, so they sort of go hand in hand. Make sure that when you're going over your study review for the final test, that you review these outcomes. Make sure that you're able to answer these outcomes. A lot of times these feed directly into the test questions that I choose. Pediatric differences that are always a focus for us in this class. So you need to review what you know about the structure of the skin, the anatomy of the skin. So as you know that the function of the skin is microbial protection, temperature regulation, vitamin D synthesis, excretion of fluids and electrolytes, pain sensation, heat and cold sensation, and the skin actually does work to rid your body of some toxins through the sweat. Melanin amount increases with age, so that affects the skin coloration. And so what that means is that young children, infants especially, have very little UV protection in their skin, but it improves as they get older and older. And this is why we don't want to take babies out in the sun for too much sun, because they can burn very quickly. All right. When you compare newborns especially and young children to adults, the skin is thinner, so it can break or tear easier. It loses more heat than adult skin, and also pediatric skin doesn't have sweat glands. So the sweat glands don't really start to appear until the beginning of the tanner stages, so puberty. So this is the reason why children need to be kept warmer in the winter, cooler in the summer. They don't regulate their heat as well. They're more susceptible to burns. Pediatric skin burns very quickly. So thermal, like you could put a child in a hot tub, for example, that's wouldn't burn an adult but would burn the child. The pediatric skin contains more water, so it's more hydrated. It absorbs more medication through the skin. So this is one thing parents often aren't aware of, is that some lotions have medications in them, so that a child could be susceptible, for example, to hormones. So some people have lotions like estrogen creams or testosterone creams that they put on themselves, and then if you hold a child or touch the child with that skin, the skin to skin contact, they can actually absorb some medications by that route through the skin. Other lotions that have medication, cortisone creams, it's very easy to exceed the recommended dosage in children because they absorb more of the medication through the skin. I'm thinking of other things that kids can absorb through the skin, but that's the one that comes to mind a lot, is cortisone and hormones. Moisture of skin. When skin is moist, it promotes more bacterial and fungal growth, and so kids are very susceptible to candida, for example, growth, especially when they're diapered, because some people let the kids sit in diapers that are wet or soiled too long. So that's something to watch out for. Remind yourself of the anatomy and physiology of the skin, because all of this will be the same for pediatrics. However, I did say that there's little to no sweat glands in children, but they do increase as the child enters puberty. This gives you an idea, a visual representation of how to, some of us are visual learners, and so you can see there's a very big difference between this child's skin and the older teenager's skin. So this sort of re-summarizes what we just talked about. Skin lesions are the first problem that we'll talk about that you can get in skin. And so, and you probably are aware of this already from your adult classes, the names for some skin lesions that are common, these could pop up in certain test questions. So macules, patches, papules, nodules, tumors, vesicles, bullae, and wheals. These are things that sometimes you'll come across in a test question, and you'll have to remind yourself what those are. Those are primary skin lesions. Then secondary skin lesions are things that arise from a primary lesion. So you can have crusts, you can have scars, keloids, excoriation, fissures, erosion, and ulcers. So these don't occur spontaneously. Generally, they arise for a reason. So, for example, a keloid is a specific type of hypertrophic scarring. It arrives from puncturing skin of individuals that are more prone to keloids. So, for example, African Americans are more prone to keloids, although certain other ethnic groups are also more prone to keloids. Excoriation, for example, that could arise from friction between something rubbing the skin, so that could cause an excoriation. Fissures are generally when the skin is dry and cracked, you can open a fissure. So make sure that you know how these things arise. Skin lesions, etiologies that are common. So you can have drug reactions that cause skin lesions. Mites and ticks and things of that nature can cause skin lesions. Infections, so bacterial or viral, can cause skin lesions, fungal, and then also injuries, so puncture injuries, burns, and pressure ulcers. All right, wound healing. Make sure that you remind yourself of the process of wound healing, which you should have already had in your adult lectures. It's the same as far as mast cells go and the stages of wound healing. The epithelialization process of the wound is the same with kids. And then the maturation of the scar is when you have collagen in the wound that becomes the collagen holds the wound together, and it takes a long time before that collagen scar tissue gets replaced by healthy skin. And then there's devascularization of that area. So this is sort of a visual for you to remind yourself of how wounds heal. So in this particular wound, you have what looks like the separated skin goes all the way down to this fat layer here. And you can see that there's a disruption between the capillary beds of the afferent and afferent blood flow to this area. And then you can see that it starts to almost knit together from the bottom up as epithelial tissue fills it from the bottom up. This tissue here, the scar tissue, is heavy in collagen. It's a little bit less flexible, a little bit less stretchy, a little bit less vascularized, and that can contribute to slow wound healing. So make sure that you're aware of the different stages of the wound healing here. This is homeostasis stage 3 to 5 days. So platelets from the broken blood vessels fill the area, and that helps with phagocytes that remove some of the infectious or dead tissues, leukocytes, which help prevent bacterial proliferation, and then you have increased capillary permeability, which will cause the swelling to the area, and that the purpose of that is to get more of the healing white blood cells to the area. And so make sure that you're aware of that process. This is stage, this is the tissue formation stage, and this takes place in the next 4 days to 2 weeks after a wound. So you see that you have a rejoining of the capillaries, and you have the tissue growing again from the bottom up. And one of the ways this works is that scar tissue, collagen, tends to shrink in over time. And so as it shrinks, it slowly brings this wound closer together while the granulating tissue is filling the space from the bottom up. Now, this is the reason that we sometimes have to pack wounds, because you can actually have the top of it heal up sometimes before this whole process in the bottom heals. And we don't want that, because we don't want an air pocket or any kind of bacterial pocket to form in there. And this is what a more mature wound looks like. This takes place in the months to 2 years. It takes 2 years for a wound at least to heal. Some people it takes longer. Some of you have wounds that you've had since you were a kid that have never gone back to completely normal appearance. But most minor scars will disappear after about 2 years. And so you can see that the skin here is a little bit more fragile. We tend to think that the scar tissue makes that area less fragile because of the nature of collagen. However, actually it's more likely to break than regular tissue. So dermatitis, this is one of the most common things you'll see in kids. Contact dermatitis is direct contact with something that causes either an allergic reaction or some sort of reaction. So in kids, they're very susceptible to getting dermatitis from touching chemicals, such as maybe cleaners, for example. Adult skin, say you touch the same cleaner and it doesn't affect your skin. And so kids' skin is very sensitive. And usually you can tell what's causing the problem by what they got into, but sometimes that's a little bit of an investigatory process to find out what they were exposed to that caused the dermatitis. So other examples of things that cause dermatitis in kids: detergents, latex, rubber, poison ivy, nickel. By nickel we mean like jewelry that is not silver or gold. A lot of times it's filled with nickel that can cause dermatitis. Perfumes, lotions. Kids don't need lotions, so their skin is more hydrated than adults. So generally kids don't need any kind of lotion applied, and it's generally not a good idea. Allergies can develop after repeated exposure to something that causes reactions. So, for example, latex usually doesn't occur on, allergy doesn't usually occur on the first contact, but on multiple subsequent contacts. And most of the hospital items no longer have latex. Most hospitals have gone latex free, but there's still latex out there in things you don't expect, like balloons, and plastics can sometimes have a latex component in things in the home. Diaper dermatitis is generally caused by a reaction to sitting in urine or feces or moisture for too long, or also can be caused by friction. So if diapers, for example, are too tight around the groin area, that can cause dermatitis there. And infants are most susceptible to this between 9 and 12 months. And the primary organism is Candida. Drug reactions can happen that cause rashes in kids. So the most common ones that we see are sulfonamides, tetracyclines, NSAIDs. Oral contraceptives in teenagers can cause some dermatitis. Barbiturates, phenytoin, which is an anti-seizure medication, benzodiazepines, morphine, those are all very common to cause dermatitis in kids. Let's see. What you'll mostly see with this kind of dermatitis is macules, papules, urticaria, hives. Usually it begins around the trunk and extends in a symmetric fashion. When you're interviewing a family that comes in with a problem like this, you want to know specifically what were they exposed to that was new. That, like, if they started a new medication this week, did they start a different detergent this week? Ask those kind of questions, because oftentimes when parents bring children in, they don't know what's causing it. The affected area for some people gets dark over a 1 to 2 week period. With some kinds of dermatitis, you can have skin peeling, and there can be pigment changes after the skin has healed. So you can have longer lasting visual characteristics that are there even after the skin's healed. Drug reactions. So I taught everybody about Stevens-Johnson syndrome when I was in teaching pharmacology. If you don't remember what Stevens-Johnson syndrome looks like, I want you to pause this video and take a second and Google this. Google pictures of Stevens-Johnson syndrome. And when you see those pictures, you'll understand why this is a potentially life-threatening hypersensitivity reaction. It's most often related to penicillins and sulfonamides, but it can occur with NSAIDs, anti-epileptic medication, acetaminophen. Most people don't have these reactions, but it's rare, but somebody could have a reaction to these, and the outcome is so bad that some people have permanent disability. So we particularly want to be careful to be aware of this with kids. Skin erosions are similar to a partial thickness burn, and the skin sloughs off. And if you're looking at the pictures on the internet, you'll see that some of the skin in the mouth even sloughs off. And the erosions can cover 10 to 30% of the body, and the erosions can be so bad that they actually affect the eye and cause blindness, because the reaction actually extends into the lens and cornea. So dermatitis generally peaks within 24 hours of the exposure, and it depends a lot on the length of the exposure too. So if you say you put in an earring that's nickel in your ear and it starts to burn, it starts to get hot and red, and it starts to get painful, usually you take it out and the thing starts to feel better right away, and usually it's fine, completely better within an hour. Compare that to if you had the inability to remove that. So let's suppose that it was nickel lodged inside your body. Now, if you didn't remove that, it would progress and get worse. Or take, for example, the difference between walking past through poison ivy and having a momentary exposure to poison ivy on the skin. Imagine the difference between that and maybe getting the poison ivy in a sock and being unaware. And the sock is got the poison ivy in there. So the length of exposure can determine how bad the reaction is going to be. And then when you have skin breakdown, any kind of skin breakdown can become infected and have a secondary infection that occurs from that. The treatment is to use barrier creams, especially cortisone. Cortisone has steroid in it for as an anti-inflammatory, and that generally helps a lot. There's also antihistamine creams, so you can get Benadryl cream that will help, and then obviously remove the allergen. Cortisone cream is avoided for diaper rash, though. Remember, this is important. And we don't use cortisone with candida rashes because it actually causes the candida to grow more. So it makes the problem worse. And there's a risk of systemic absorption in kids. Don't use powders or cornstarch on dermatitis because sometimes they make the problem worse. And then you can also use wet compresses that are warm, or you can use a dry warm compress. And this is to promote comfort and pain relief in that area. Distribution. So you want to pay attention to how the distribution of the dermatitis is to give you a clue of what caused it. So for example, if you have a rash on the trunk near the pants, so it could be related to the nickel snaps in the pants. It can be related to buckles and things of that nature, sunscreen. If you have something on, say, the earlobes, then you know it's high likelihood it might be related to an earring or something of that nature, or maybe on the neck, then it's probably related to perfume that you applied. So this is part of your interview process when you're taking a history. This right here is Candida, and it's a very severe case. You can see that it spread up and out. So it probably started here in the diaper and then it went up. And this is obviously a worst case scenario of diaper rash. This would prompt me to actually open a CPS case because this doesn't happen unless there's neglect. And this is why I always say always, always, always look in the diaper when you're looking at children. This is the same, this is seborrheic dermatitis, and this is generally seen on kids. It looks like newborns. It looks like it looks like candida on the scalp, but this is a slightly different kind of yeast. But so it's not exactly the same. This is called cradle cap, and because it looks like dandruff, it can also occur around the mouth, the nose, the eyelids, and then there's eczema. So babies and young kids can develop eczema, and generally eczema and asthma go hand in hand. So if a kid has asthma, they'll be more prone to eczema, and if they have eczema, they'll be more prone to asthma. This is just known to be on the same genetic allele. And so these are something to be aware of. I would ask that question, say if I had a parent bringing a child in with eczema, I would ask if they had any trouble with breathing, or if they needed any inhalers, or if they had a chronic cough or anything like that. Sometimes eczema can be triggered by things like mites, pollen, different foods, irritants, hormones, stress. So these are things that you need to ask about in the interview process. This is impetigo, and we did kind of do a quiz at the beginning of the semester where I had put all these in a Kahoots. Maybe I'll show that at the beginning of the next class again and see if you guys got better at identifying the different kinds of rashes and infections. The thing that makes this one in particular stand out is right here, this word here called honey-colored crust. This is a cardinal sign of impetigo, is honey colored. You'll see that verbiage used often. And this, you don't want to scratch this off or scrub it off. You can soak it and gently wipe it off with gauze, but then it's one of those where you wipe and then you throw away, wipe and throw away. You don't want to keep using the same piece of gauze or washcloth. It's very contagious, so you can reinfect or you can infect other kids in the house with it if you want to get rid of those. This is often caused by Staph aureus, MRSA, and so again, that's why this is so contagious, and it can go up into the nares, and it can even be transmissible through droplets. So this kind of infection, the child would need to be on isolation if they had it, say in the hospital. Let's see. All right. This is one that you should have seen in the adult worlds. This is the purple mark around here is them marking it with a pen to see if it's getting bigger. Of course, this is cellulitis, or also sometimes called folliculitis. The difference between cellulitis and folliculitis is just really if the infection arose from a puncture in the skin or from a hair follicle. That's the only real difference. And generally, again, this is caused by Staph aureus, and this would need to be treated with IV antibiotics. But sometimes this can be caused by a puncture site. One of the kids I saw had been walking barefoot through a pumpkin patch, and so it looked like a spider bite, but it was really a puncture from a dried, hard piece of pumpkin stem. This has to be treated fairly quickly, and the thing we're concerned about is this can quickly become necrotizing fasciitis, or it can become move into sepsis or osteomyelitis, because that infection, if it gets into a bone, that's very difficult to treat. Viral infections. One of the things you want to think about with there is a pox virus called molluscum contagiosum. So that one is transmitted by direct contact with an object. Can also possibly be spread by sexual contact. Warts. These are infected epithelial cells. These are transmitted by direct skin-to-skin contact or mucous membrane contact. Usually these go away on their own. Children, when they get these, they're not generally that painful, but just painful or annoying enough that kids tend to suck on them or bite them, which could cause more spread of the infection. They have bitter apple drops that you can put on there to prevent the child from biting it or sucking it. Fungal infections, again, so another place we see oral candida with kids is common. With kids that are at the age where they're bottle fed, they can get candida from poorly cleaned bottle nipples, or also it's common in kids that use steroids for any reason, especially asthma with the steroid inhalers. You'll see that. So the oral mucosa gets inflamed, and children generally, when they have that, they stop eating, and so that they can then progress into them losing a lot of weight. So there's different things. It can be also caused by immune deficiency, and we treat it with oral nystatin, which is an oral solution of an antifungal medication. Ringworm is actually not a worm, it's a fungal infection, and that can be found in the skin, hair, nails. It does look like a worm because of its circular appearance, and this is spread by person to person or at contact with a contaminated object. So for example, sandboxes that kids play in outside, it can be an animal had a bowel movement in that sandbox, and that can be the cause. This right here is tinea capitis. Um, sorry. And this one right here is tinea corpus. So drug reactions. Um, as I said, anytime you have kids on any kind of medicine, you've got to watch them to see if they're having an allergic reaction to it. And then most of these are treated with antihistamines, topical corticosteroids, compresses, and baths. Chronic skin conditions. So we've probably gone over eczema enough, but acne is the next one. So this one we tend to see in newborns either right after delivery, and it's caused by the mother's hormones passing over to the child during the delivery, or then it should go away, and the next age group that you'll see it in is 12 to 25 year olds. So as they're starting to get their adult hormone levels, you'll start to see a period of time where they're much more prone to acne. So this is generally caused by increased sebum production. So one of the effects of increased hormones in teenagers is that they do start to produce more sebum, which is oil. They get oily skin. They have increased amount of bacteria, because maybe they previously didn't have to wash so much because they didn't have sweat. Now they're more sweaty and oily, but maybe they haven't adjusted their bathing habits yet to accommodate that. It usually occurs within 1 to 7 years of onset of puberty. So here it's saying if you have a child that has precocious puberty now, so some kids can get puberty early, and so that's defined as less than 7 years old. So if you see a lot of acne in kids that are younger than that age, then you would need to follow up, because that could be a sign, an early sign that they're in precocious puberty. So some types of acne, though, there's lots of different types of acne, but they don't all form scars. There's one kind that forms permanent scars, and that's one of the kinds we're most concerned about with kids, because those permanent scars can be lifelong. They can alter the child's self-esteem. It can cause them to be bullied or made fun of in school, and really it's caused by a bacteria. So, and that's kind of the heartbreaking part for me, is that if it's that kind and it's not recognized, it's totally could have been cleared up and preventable with the administration of antibiotics. Some kids that have really stubborn acne, they start Accutane. For girls, this is a problem because you have to take a pregnancy test fairly frequently with this medication if you're female, because it does cause birth defects. And then most people don't know, but there's a higher risk of suicide with Accutane. So there are some risks to taking Accutane. Antibiotics, like I said, will sometimes clear up the most serious types of acne, and those are the ones those are the populations I really want to help, because they're the ones that are going to have those scars go very deep. And once you have that kind of scarring, it's very difficult to remove those scars non-surgically, because they go so deep. They can do dermabrasion, but they can only abrade so much of the skin down before they're at the bottom of the basement membranes, where you can't go deeper. If you go deeper than that level, you can't regenerate the same kind of skin. So So they can only remove so much of that. And this sometimes the scarring goes even deeper than that. Then the only thing they can do is inject fillers and whatnot into those holes, and all of that is considered um, cosmetic and might not even be covered for the child. So parents often are not able to afford to get this kind of treatment for their children. Other treatments for bacteria, for acne can be certain types of oral contraceptives in girls will cut back on acne. Benzoyl peroxide is one of the oldest and best medications that we've had. It's been on the market for 70 or 80 years, and it's still like one of the most effective treatments we have. So you want to, if you're the nurse taking care of this child, you want to teach them how to care for themselves, because when sometimes kids become very self-conscious because of acne, they'll think, well, common myths with acne are that it's caused by eating chocolate. Well, it might not, it's probably not related to eating chocolate at all. Some people say it's because you eat fries. It's not really associated with eating fried foods unless you touch your face with that oily stuff on your fingers. So teach them not to touch their face, but other than that, they don't have to cut out fried foods and chocolates or anything, because that's not the direct cause. Other myths, sometimes kids can scrub their face thinking that's going to help, and it actually can make the problem worse by disturbing the natural flora. And sometimes kids will use really harsh cleaners, harsh detergents on their face to clean it. Again, that can make the problem much worse. So make sure you teach kids how to take care of their skin properly when they have this problem. Psoriasis is another autoimmune problem that causes skin problems. So this is chronic in people. It causes relapse, it comes and goes frequently. It's itchy, and it can look disfiguring to the person. Um, so epidermolysis bullosa, which is hard to say, bullosa. This is a rare, severe, chronic blistering skin disorder. I'm not going to test you on this. This is pediculitis capitis. So, of course, this is lice, and since it's pediatrics, we know that kids are more susceptible to lice than just because of the way that kids interact with each other, they tend to spread it. So outbreaks can occur frequently when kids are in daycare or elementary school. That's one of the most common times for there to be outbreaks. The schools aren't allowed to tell anymore. Well, some schools are different if they'll even let anybody know that they have lice, because they don't want the child that got the lice first to be ostracized by the kids. So they try to protect the identity of whoever had it first, but kids kind of know. And so this is kind of a tough thing to deal with if you're the kid. But prevention is the best thing to teach with this. Of course, no sharing of hats, no sharing of hairbrushes. There's sometimes it can be spread at a sleepover if the kid had lice and they were sleeping on a pillow, and it spreads that way. So teach how this is prevented, and the cure is pediculicide shampoo. And so what that does is it kills the eggs. The then it's so you use the shampoo. A lot of parents think more is better, so they'll use 2 solutions of the shampoo, but you want to teach them that this is absorbed through the scalp, and it can be toxic to the child if they exceed the right dosage. Scabies is more common actually in elderly population, but can still occur with kids, and it's highly contagious. Again, skin to skin or sexual contact with this. And for this one, you have to buy a scabicide permethrin lotion, or melathione or oral antihistamines are the treatment for this. Hemangiomas, these are a very interesting thing. Um, I had a patient that had this and she was cute as a button, like about 18 months, 2 years old almost. Um, and what the hemangiomas are is they're a little red looking um, birthmark, but they're raised a little. And what they are is embolized placental cells that can get into the body of the child. And the reason that's important is because there are some uh, stem cells in the placenta, and so wherever they go, they can start to grow and proliferate. If they're on the surface areas of the skin, then that's not a problem, but um, they always want to follow up if they see this because it could actually be anywhere in the body. If the placental cells embolized throughout the child's body, then that could mean that these cells are proliferating in the liver. They can proliferate in the lungs or wherever those cells ended up. And so sometimes it can be very serious, as it was for the child that I was caring for. She was very severely ill because it was in her liver and they had to go in and resect that. Complications can be due to rapid growth and pressure caused by these embolized tissues. And especially they can affect, like I said, in the child I was caring for, the liver. That's a major organ that you don't want to have disrupted. They can also develop in the eyes, ears, airways, so they cause different problems based on where they are. This is a pressure ulcer. You don't usually see, this is the scalp of a child here. You don't usually see kids get pressure sores. It's pretty rare because they're not that heavy and that means they don't weigh down on the skin as much. Remember, pressure ulcers are caused by skin that's being pressed onto another surface, and so this to me, this happened on the back of the head. This could only happen if the parents didn't pick the child up, and I've seen this where sometimes babysitters. This happened to me once where the babysitter told me that she hadn't picked my child up all day long because they were sleepy, and so she didn't need to pick the child up. But I found this bump on the back of or a red area on the back of my child's head, and luckily it didn't form into a full-scale pressure ulcer, but it can. Like I said, you could see it more often in kids that maybe they have a neurological problem or they're unable to move and they weren't turned. So that's possible. Or like in this case, it could be a neglect where nobody picked the child up and just let them sit there. So they're more susceptible when they're before the age where they can roll over. So that's very important to be aware of. So in this case, you would do a Braden scale. That's the scale associated. So as you know, it's same with adults. The ones that are most at risk are immobile, neurological deficits, poor nutrition is a factor, poor hydration, edema, anything like that. So other times you'll see this more commonly in kids is if they have leg braces or casts. If the leg brace or cast is on too tightly, that will lead sometimes to a pressure sore. So as with adults, this really isn't any different than with adults. The common sites, just any bony prominence that's, comes into contact with another harder surface. Injuries to the skin as far as burns go. So there's thermal, chemical, electric, and radioactive burns. We don't talk much about radioactive burns in this course, but you'll get that probably after graduation when you do your CBRNE training. Thermal burns, so thermal refers to touching something too hot. Chemical would refer to touching something like lye, for example, can chemically burn the skin, or an acid. And then kids get electrical burns once in a while. It's common if they, say, chew through a electrical cable, which kids will do sometimes when they're at that age of exploring. So the assessment, there is a percentage of the body surface area that you'll want to measure. Usually, so we don't have a burn center here in Reno. So if they have somebody with extensive burns, they'll often send them to a burn center. So we won't see this as much here, but they do estimate the percentage of body surface area that's been affected, and I have a graph that you'll see. I don't test on it, so you won't have to memorize it. And we also look at the severity of the burn. So there's first degree, second degree, and third degree. Also, an alternate name for this is superficial partial thickness, or full thickness. And so you'll want to know the different classifications here for testing purposes. First degree or superficial partial is the outer layer of skin and it heals quickly. The second degree includes the epidermis plus the upper dermis. These take a little longer to heal, 10 to 14 days. This is like common with blistering types of wounds. And then you have third degree or full thickness, and it incorporates all the layers of the skin and maybe even down into the lower tissues. So it's possible for the burn to be so severe that it goes down into muscle and bone. And so this one you can tell because it's not as painful, because the at least in that area, because the layers of skin that have pain reception are gone. So it's actually, believe it or not, more painful to have a first or second degree burn because you still have those pain receptors. Full thickness burn, there's no way the skin can grow back because too much of it has been burned, so skin grafts are required. This is, and we've talked about this in prior classes, this is probably caused by a child pulling a hot cup of coffee on themselves or a hot pot. So that would be, this could be a second degree burn. It's hard to tell from the picture, first or second degree. This is obviously an electrical burn, and this is probably caused by the child chewing on an electrical cord. And you can see that the tongue is involved here. So that's probably very painful. This burn here is probably very painful and would take a while to heal. Probably doesn't need skin grafting though. Full thickness burns. So this is the most dangerous ones. When you have encounter a child that's got a full thickness burns, one of the first priorities is ABCs, airway. If there was like a house fire, for example, we want to know if their airway's patent first, and we'll talk more about that. But the next thing is, because of the heat of the burn, all the fluid can be gone from that area, and fluid from the rest of the body kind of rushes to try to make up for the deficit. So there's fluid shifting and going on in the body. So after airway, the next thing we're most concerned about is fluid balance and electrolytes. Electrolytes that get dumped into the system when you have burnt skin is potassium. So there's often a potassium imbalance. And then you want to promote skin perfusion because often some of the tissue that is hypoxic can actually be saved if we are able to promote tissue perfusion. One of the best things we can do to promote tissue perfusion is to restore adequate fluids. So also to not place the child on the burned tissue, so we want to not have any pressure there. The next level of priority here is pain, because at least in the first and second degree burned areas, those are extraordinarily painful, and especially for kids because they're more sensitive even to pain. We want to prevent infection. That's our next priority. That doesn't kick in till about 8 hours after the burn, because a couple of things. You've lost your barrier and your natural flora to prevent infection. And so then as soon as that skin is broken, there is about an 8-hour window till you start having bacteria proliferating. And so this would be a great question on a test, because it would ask you to list things out in the list of priorities of when you have to fix it, right? And then salvaging viable tissue, like I said, so you don't want to, you want to save as much skin as you can. And then maintain the child's temperature. That would be another priority, because the more of the surface area that's affected, the least likely it is the child will be able to regulate their temperature. And then always be concerned if you see the word circumferential in a test question. Circumferential is almost always bad. So it could be talking about a compartment syndrome, or any kind of test question where they use a circumferential anything. Usually they're trying to tell you that the blood supply is cut off to the area. So if it's a circumferential burn, think of the skin can be like beef jerky, where it shrinks and it gets really tight, and it can actually cut off the circulation below that area. So think about this in terms of blood supply, and that you have limited a period of time to act before you're going to have loss of limb. So that's an emergency. Full thickness burn care is, like I said, we don't have a burn center here in town, but if you were interested in that, it would go on to things you need to know about are escherotomies. So that's when you have so much of a black scarring area that area won't heal unless you remove that. So they have to usually go in and surgically remove the eschar, the scar, so that you can have a healthy wound bed to continue to grow new skin. Also, there's debridement, so you can debride a wound, and that is, again, removing some of the dead and non-viable tissue. So you can actually surgically remove it, or there's actually chemical debridement medications now that can be put on or in the wound to promote that debridement. Grafting is something to consider next, as they look at healing the wound. And then assess things like eye, lip, hands damage, because these are things like, if, for example, if you burned an eyelid and you're not able to shut the eye, it's highly likely you could go blind in that eye unless something is done, because the eye needs to blink every so often in order to not dry out. So these are things. Lips, same thing. If your lips are affected by a serious burn, that can lead to cosmetic problems, obviously, but also problems with eating, drinking, so it's more serious. Hand damage, we're concerned because they could lose the use of the hand. And then perennial wounds are pretty significant, and it changes the person's function. Things that we're concerned about later is, of course, pain control, preventing infection. Contractures develop when, say, your skin, let's say your arm is burnt 100% in your arm. it's possible that you wouldn't move that arm a lot because first it would hurt, but secondly, as the skin's healing and getting scar tissue, it's not as flexible to move. So what can happen then is a contracture. And that's not good because you can lose a lot of your mobility in that affected area. And so the only way to prevent that is to do painful physical therapy on it continually. And that's hard for kids to do. Um, ensure adequate nutrition. So this is a key thing that I'm going to go ahead and put a little star here so that you know the kids need about double their calorie or maybe even triple their calorie intake when they're recovering from a serious burn, because it takes a lot of calories to rebuild all those tissues. So they go into a hypermetabolic state, and that state can be that can mean that they're struggling with malnutrition while they're trying to heal. And if you don't give them adequate nutrition, they will become malnourished. Um, Anxiety management, there can be a lot of anxiety around various aspects of the wound healing process, body image issues. It says burns are most deadly within the first 24 hours due to hypovolemic shock. So this is like the number one concern you're going to have with burns is that first 24 hours. There's a lot of fluid shifting going on, and there's a lot of electrolytes that are shifting around in those spaces. Especially if you think about when we give fluids into a patient IV, what would happen if their cells just let it leak out? Imagine the reason that you don't leak fluids out of your skin all the time is because you have tight junctions in between your cells. But in the first 24 hours after a burn, those tight junctions can melt because they're made out of wax. And so for the first 24 hours, you can give continual amounts of fluid and it'll just leak out and pour out of the body. So they have to be very, very on top of this fluid balance. This is the way different kind of burns might look as far as so you can visualize the amount of tissue that's affected, the depth. This is ways that they estimate the extent of the percentage of the body that's burned. It's different than the adult measurement, so this is not something I would have you memorize, but like, you know, you might wonder when they say somebody was burned over 30% of their body, how were they able to measure that? And it's through one of these kind of charts. And like I said, it's different for adults than kids because their body proportions are different. This kind of burn here could have been caused a couple different ways. It doesn't say what caused this kid's wound, but I would guess this looks like the child could have been burned by picking up a hot boiling pot, or maybe they were burned in a car fire. I'm not sure. It's hard to tell. Fireworks. This could very well be a burn from fireworks. Anyways, this is a significant enough amount of burn on the body to cause this percentage here is enough to cause problems with fluid and electrolyte status for sure, right? And then your concern here for the arm would be contractures, right? So right here at the elbow, what will happen if they don't keep moving and working this arm with physical therapy? So this also, you might notice the dressings. There's special dressings that go on burns. They aren't the same as regular dressings. This yellow stuff right here, that is actually a type of dressing that's infused with petroleum jelly to keep you never want the burned the burn to dry out, so it's always got to be covered with a non-adherent what was the word I was looking? Petroleum jelly infused kind of dressings. Sometimes they use silver nitrate in these wounds to prevent infection as well. This is something, so when you get scar tissue after a burn, It's called hypertrophic scarring, and the scarring is very thick, and it's hard for it to be flexible, and that's why you get contractures. One of the things that they've discovered recently is that if you put pressure on the skin, it doesn't cause as much hypertrophic scarring. So this shirt here is a special pressure garment that prevents hypertrophic scarring, and they've been pretty successful with that, preventing some of the worst kind of hypertrophic scarring in kids. So burn prevention is, of course, a very important topic with kit to bring up with parents so that they don't have this happen. So you obviously want to differentiate between accidental burns and possibly abuse burns. So again, this is a case where you have to ask yourself sometimes if the burn makes sense. How, does it look like cigarette burns, for example? Does it look like it's on the feet? Because sometimes parents, abusers, will dip the feet in boiling water to punish a child. Or if it's an accident, you can tell because school-age kids are most likely to get burned by experimenting with, say, when kids discover that they can make fire by taking hairspray, for example, and lighting it with a lighter. Well, they could get really burned doing that, but it's not abuse. It's obviously accidental. Hot appliances are most likely to be involved if they're preschool age kids. And toddlers, thermal burns from reaching for hot coffees off of surfaces, or getting into something they shouldn't have gotten into, or biting through electrical cords. Prevention, again, is really important as far as teaching parents how they can lower the risk of the child getting burned. So, you want to teach them, for example, to turn the handles of pots towards the center instead of outwards on the stove. Teach them to not drink hot liquids in reach of a child. Other things can be setting the right temperature on the hot water heaters. So most parents of small children, they have the water heater up too high. I think most commonly people have it around 128 degrees in the hot water heater, or even 120. That's too hot. If you have children, that can burn the child if they turn on the hot water. So they have you usually reduce it down to like 110 is safer for kids, because by the time it gets through the house and comes out, it's not 110. It's more likely to come out around 100, 103. Let's see, keep matches and lighters and all that away from kids, of course. And smoke detectors is always a big thing. Check the batteries and annually. This is an example of a non-accidental burn, and this is associated with child abuse. And you could tell because this child was too young to have gotten their feet into a tub, and the burn is more extensive than you should have seen from a tub. This is more likely associated with the parents dipping the child's feet into boiling water. Other injuries, burn injuries, can be sunburns. So especially the more pale-skinned children are more susceptible to burning. But even dark-skinned children can also get serious burns. Hypothermia. This is the opposite problem. So anytime you're exposed to, your body temperature drops below 95 degrees Fahrenheit, that's hypothermia. It's mild. Moderate is 82 to 89%, and severe is a core body temperature less than 82. So of course that affects your ability to attract oxygen molecules to your blood, and so what happens is you die of hypoxia because you can't oxygenate your blood when your body's that temperature. The treatment is to reheat the body slowly, so you don't just plunge a child like this into warm water. They have to be reheated very slowly. Frostbite, obviously the problem with this in this is that if you lose blood supply to, say, the fingers, toes, ears, that can become necrotic and fall off. So bites, animal bites, insect bites, all those kind of teachings are included in this section. So know how to teach the parents about preventing insect and animal bites. Contusions, like crushing contusions, can happen, say, bicycle accident, for example. You can get gravel in the skin. Penetrating injuries, those can damage the skin, of course. Stingers, nails, those are common injuries to kids. Lacerations, the thing we're concerned about that is it may need to be sutured.